I really want to thank all my speakers who have contributed so richly to this course, and it was one of the most highly attended course in 2019 in URETNA in Paris. So I'd like to thank Dr. Ajay Arora, Dr. Lalit, Dr. Azad, and Dr. Vishal for contributing so much. I'll do a very good morning to all of you, and welcome to this course. And I hope that you learn a lot from our experienced speakers. And just I want to inform that Dr. Azad will not be available today because he couldn't come. So we are left only with 4 talks. So our first topic is the management of submacular hemorrhage during vitrectomy for retinal detachment. So this course will highlight on the complications which occur during a vitreoretinal surgery and how to manage it and how to get a successful outcome, and is probably useful for those young budding vitreoretinal surgeons, and I think all of us must have faced these complications. So we'll talk with our first topic. We'll start with Dr. Ajay Arora. I think he does not need any introduction. So sir, please start with your topic on the management of submacular hemorrhage during vitrectomy.
Thank you, Bhuvan. And good morning, everybody. Good morning, Vishal, Dr. Lalit, Dr. Azad, if he comes. So my topic is on submacular hemorrhage during vitrectomy, how to proceed. So the submacular hemorrhage can occur because of an inadvertent retinal damage, bleeding while peeling a vascular membrane, doing a drainage retinotomy, relaxing retinotomy, or when you get a subretinal bleed while doing a drainage for SRF in a scleral buckle. Now you must pay attention to unusual bleeding. Why? Because whenever there is bleeding, it clots and it forms a membrane. And it forms a membrane, you have to peel it. It may compromise your view. It can go subretinal. So what are the steps which you should take as a preventive measure? You must make sure that the patient's BP and heart rate are controlled. Initially, when the bleeding occurs, you have to exert mechanical pressure, maybe with the tip of a cutter. You can raise the bottle height, you can inject PFCL, remove the blood from the macular area, which is away from the macular area, or you can switch to air if you have done the dissections towards the end and complete a vitrectomy under air. You may add thrombin during infusion and can also add adrenaline during infusion. So this is just to show you how when dissecting out a vascular membrane, we can exert pressure with the edge of the cutter. There's a bleeder running, but if I exert the pressure, I do a proportionate reflux under the membrane, create a passage. You can see those bubbles. You will be able to avoid injuring the membrane, and you can easily remove this membrane. So this is just to show you in a vascular membrane how to avoid bleeding occurring on this thing. If a bleeding occurs, you can actually with your cutter use a proportionate reflux, wash out the blood before a membrane forms. In case there is a bleeder, you can use a chandelier, use a thermocautery at the same time. So you can visualize, you can remove the blood, you can aspirate the blood, and also use cautery for that. So that will help you. And as I said, you can also use endo laser in addition. You can do dissection under air, and you can use a PFCL assisted dissection. There was a small study which was published way back. We don't use it often, but I think it has a relevance, is to use bovine thrombin. People have used human plasma thrombin or a recombinant thrombin, because recombinant thrombin doesn't have the problems related to diseases, viral infections, and can be very, very useful for controlling bleeding on the table. This is just to show you some videos. You've had a bleed, you can see here. You had a bleed here, which is a large one. We injected PFCL, and then you can, there's a drainage retinotomy where you can go inside either with a soft tip or a hard tip, or with an end gripping forceps, and remove the heme, do a PFCL siliconal exchange, do endo laser, and you are absolutely done. So this is another patient where there's a large subretinal bleed which is dragging onto the macular area. Do a drainage retinotomy superiorly. You can see a retinotomy is being done. A soft tip has been put in. PFCL has been put in over the macula to displace the blood from the macular area. and then you remove this heme with a soft tip, do a fluid air exchange, remove the PFCL, add silicone oil, do endo laser, and you're again done. So you have to get in early, remove the blood before it clots, and do the needful. In case the blood has clotted or there's a large blood, this is what I got this video from Dr. Subhendu. So it's a large vitreous hemorrhage with a subretinal bleed. I'll just show you the part which we wanted to show, that you can create a large relaxing retinotomy, go in subretinally, and remove the blood by an end gripping forceps or a soft tip or a hard tip again. Once the blood has been removed, again fluid air exchange, silicone oil injection, and it can be lasered in the end, and it works fairly well. These are some of the cases which is a dreaded complication of large suprachoroidal hemorrhage. I'll not discuss much into this, but we have treated a large number of them referred cases where you can drain it by putting in an EC maintainer, a partial thickness sclerotomy from outside, and then inject PFCL into the vitreous cavity, do the vitrectomy, remove the blood, and these are some of the examples. So the take-home message is: must plan well preoperatively, have a good systemic control, address any bleeding during vitrectomy immediately. There should be liberal use of perfluorocarbons. Infusion pressure must be elevated for a short duration of time till you can control the bleeding. May need to close the port. Fold up your hands. Do not panic. Plan for the next steps. Judicious use of thermocautery and simultaneous aspiration while you're doing a thermocautery. Therefore, utility of using a chandelier in these cases is very useful. And in severe cases, you can always close up, go back another day, and intervene subsequently. Thank you.
Thank you, Dr. Ajay. Any questions from the audience? We've got lots of time. So,
sir, any tips to remove the clot?
My
the clot that forms, sometimes the clot forms on the posterior pole by the time you finish a membrane dissection. So, like any tips to remove that safely without tearing the retina below?
Forming on the retinal surface. So the best way is that you remove the clot before it forms, but many times it does not happen. So what I do is that there are 2-3 ways of doing it. You could either support the retina adjacent to that with PFCL, take in an end gripping forceps, create an edge. But what we have found out is that you should actually, if you're using a constellation or any other machine where you can have a reflux, proportionate reflux, you have beveled cutters available now. Go close to the blood, and then there you perfuse fluid. You create an edge between the retina and the clot. Once you create an edge between the retina and the clot, you can. So I'm presenting a similar thing tomorrow in retinos, where you can actually, I didn't wish to present it here. You can create it below the blood, and the whole blood will come off. So a counter support with PFCL with a minimal traction without causing force on the retina. So I hope you can imagine that. So either use end gripping forceps or this, any of these things can be used.
So I would just like to add something with Dr. Ajay has said. I think sir has highlighted everything. So one set is important that we should try to prevent the formation of this by using PFCL as early as possible. But once you have formed a clot, which is involving the fovea large clot, it is very important to remove that clot, which will cause the loss of vision. So there is one more way in that you have to create a retinectomy, an inferior 180 degrees or a temporal 180 retinectomy. You reflect the retina and then you have to remove that clot. So this is one way which has been described during surgery, because you just can't leave a very large clot at the posterior pole. So, and I said, sir, I don't think it will, with this technique would be better, but what you do is, which is conventional, which has been described in textbook, that you create a 180 degree retinectomy, you reflect the retina, remove the clot, and then with PFCL again settle it and go forward. This is I'm saying for a huge clot which is present at the posterior pole. A minor streak or something, better avoid it. Don't do anything. Leave it alone.
Subsequently, you can always use tissue plasminogen activator. And that inject it in the vitreous or subretinally What I have done unconventional, I wish I had the video to show you with two cases like that. So I created two drainage retinotomies. I created one retinotomy from where I perfused fluid and another drainage retinotomy from where I put in a soft tape. So there was an irrigation going on from one side, aspiration happening from the other side, and using a chandelier. It worked very well.
I will show a video of that. I have it. If that, I think time. Please.
At one point, I was doing a diabetic vitrectomy. First, I did the worst eye, then the patient accepted to get the other eye operated. And there was a bleed operatively. I raised the pressure for less than a minute. The next day, the patient was PL negative.
So, you're talking now about diabetic vitrectomies and bleeding. I think I will be speaking on that. Probably we'll have the discussion after that on this topic. I'll be discussing all these important points. So now I think we can just focus on Dr. Ajay's presentation, which was occurring of a hemorrhage, of a submacular hemorrhage during vitrectomy, during an uncomplicated surgery. This I'll discuss in detail.
Yes,
please.
Yes, sir.
About removing the pre-retinal clots,
Pre-retinal or subretinal?
pre-retinal or even in some cases subretinal, in case there is a retina detached. There is an instrument that I have designed called as aspiration scraper. A couple of years back it was Natarajan award winning paper. The thing with that, it's a diamond dusted cannula which has a bent tip, and you can actually where there is a clot which is stuck, you can gently scrape the clot off and then take it off the retinal surface. If it's a large clot, then you can cut it with a cutter, but it's easier to remove the clot from the which is densely adherent to the retina. So that works quite well. And even in subretinal area, you can create a relatively small retinotomy and go subretinally. Since it goes along the curvature of the globe, we can actually massage the subretinal area and remove the clot, and then it comes off much more easily.
Yeah, another thing, Manish, that is you can use a combination of a finesse loop with an aspiration. Now, finesse loop, if you see when you extend it, you get the entire finesse loop out. Now, if you do not extend it full, you get half. When you get half, the amount of force exerted by half finesse loop versus a full finesse loop is different. With just a tip of finesse loop pointing out, you can actually create an ILM peel. So you do not completely take it out, just a little bit. It is firm. Fully, it is not firm. So you want to remove the blood, take it out fully, take the finesse loop, aspirate, and have an active aspiration on the other side. Works beautifully.
With aspiration scraper, you do these things with single hand.
So
no, sir. You have a chandelier. You have one hand finesse loop and one hand aspiration.
Sir, see, I think what you just mentioned is very good for a pre-retinal hemorrhage. But just for the audience, I just want to make it very clear. You should not go behind the blood and do a blind scraping in the submacular area.
Not submacular, but it's not blind. You can actually see what you are doing.
Okay. Because as I said, the best way for a
problem is anything trauma to retina should be minimal.
Yes.
See, then, sir, you may do surgical erosion by going in the retina.
If there is a clot subretinal that you want to take out, actually,
If it is submacular, we are talking different.
Yeah, that is submacular is the most important.
Extramacular is not a big deal.
We can even leave it.
You just do retinotomy.
Exactly.
Generally, it comes out. And finish loop, may not finish loop. The problem is they have,
Yeah, they will.
They traumatize the retina more than.
Probably the choroid also can lead to hemorrhage, more hemorrhage. So
And so the final is that one more simple way of aspirating all this blood is the simple backflush which we use.
Yeah, simple.
And not just partially cover the hole so that the aspiration is controlled, and then you can do it. It's a very simple and
I'll
non-traumatic
show
way.
you. There's a big mathematical formula to calculate the amount of force generated by fluid within fluid in air. So I'll be presenting that tomorrow. When you do a back flush and push the fluid, and versus using the same fluid in air and hit any object, the force generated is totally different. So when you use a back flush, as Dr. Vishal said, in a subretinal space, you use minimal force, but it dislodges the clot and then aspirate.
So I think there are a lot of questions. Just to summarize, sir, I just want
to make two points. Can I make a point? I had encountered a similar case of CNVM bleed. I was treating with an anti-VEGF therapy. CNVM bleed, subretinal bleed. when I was treating with an anti-VEGF therapy, landed up in a rectum RD. So it was we planned to set the RD with the retinal indoor. I was wondering whether I should go back behind the retina and then touch that CNVM or remove the clot or not. Just I wanted to know like how to tackle these kind of cases when the risk of rebleed when you touch the active CNVM is high, or whether to just settle the retina and leave it off, or you need to go back and then remove the blood clot as well during the vitrectomy.
So I personally feel that if you have a CNV which is bled, and it is causing an obstruction in the vision, you must first make sure that you've given your anti-VEGFs, because you have to control the CNVM. If the blood, if you follow the standard protocol, which we wait for some time for the blood to absorb on its own. Otherwise, we go ahead, do the vitrectomy, give anti-VEGFs. We used to a long time back create a retinotomy, remove the CNVM subretinally, causes a lot of scarring there. If you can just control it with anti-VEGFs, if it is extramacular, do a laser. I think that's what should be.
Mike.
What I want to do is a very small hamlet, leave it and depend on pneumo displacement.
Yeah.
At the end of the procedure, inject gas, and pneumo, that works the best.
Yeah.
That, in my hand, most works the best for that.
So yes, sir, I think CNVM bleed are different stories, and if there is a CNVM with a large subretinal bleed, I think we have to do a vitrectomy. Then depending on your expertise, it also has been described that you can give a subretinal anti-VEGF along with a subretinal tissue plasminogen activator that will liquefy the blood, and then you can inject gas to displace it. So these are the ideal management for a large subretinal bleed. Again, if the subretinal bleed is small and does not require much intervention, probably only gas with anti-VEGF will be sufficient. So just to summarize what in Dr. Ajay's Arora, just to get the get-home message, if you have a submacular bleed which is extramacular, I think you don't have to fight very much for it. As much you're comfortably able to remove it, you can make a retinotomy and remove it with the back flush. If there is a large submacular bleed, then it can lead to grave prognosis. That is the important part. First of all, you have to prevent it with liberal use of PFCL. And if it occurs, the best method is you have to create a retinectomy. You have to lift the retina and remove the clot. That is the most atraumatic way of without damaging the underlying retina and the choroid. And once the clot is removed, you can just proceed as a normal giant retinal tear surgery. So I think now we can move to our next topic. Our next topic is by our president, Dr. Lalit Verma. We are meeting him after a very long time, and we have learned so much from him. And I think also today we all will learn a lot from him. He'll be speaking on my infusion cannula is not in position, subretinal or suprachoroidal displacement of the infusion cannula. So please.
Thank you, Bhuvan, for making me part of this interesting session. In fact, all vitreous surgeons have nightmares virtually every operating day. And especially if you have some issue, I generally cannot sleep on that day because of whatever trauma I may have caused. So therefore, I believe in minimal possible manipulation. Otherwise, you tend to cause a lot of iatrogenic issues. So I'll be describing one or two cases where I have faced this situation of subretinal cannula. So no financial disclosure. So in all vitrectomies, everybody is taught first in, first out, and there is no compromise on this. And before we start vitrectomy, it is mandatory to check the location. But there are situations where issues may occur, like a bullous RD, where you see people go inside, and where thickness is expected to be more, something like CD along with RD, uveitis patient, choroid is thicker, or a hypotenuse globe, or endophthalmitis, small pupil. So these are practical situations where I have found, this situation may occur, that cannula instead, even though you may take all precautions, it can. So I'll illustrate by this small video. This was a patient where we were doing vitrectomy. You see, first port made here, and you could see that that MVR was inside. You could see this location. There was some tissue here, so I was not very sure whether. So made the other port. This is a port straight vertical. In such situation, don't go a two-plane incision. Go straight inside. Actually, this should have been made in the opposite quadrant, and then try to cut this tissue which is obstructing the view, and you may have to depress it. But if you make this port here opposite, then you will do a better job. And just cut this tissue and remove that, and then check again whether it's okay or not. So this was a patient of endophthalmitis, where we were, doing a vitrectomy. So here again, the only trick here was to do a needle infusion. Take this sharp needle and infuse ringer lactate or BSS, what you are doing, and make the globe slightly firm. This is a hypotenuse eye. Once you have made the globe firm, then you can take this cannula again, single entry, straight entry, rather than a biplanar or triplanar entry, because of thickness of the choroid, and go straight inside, because this cannula is more likely to be inside rather than the curved. Now you can see, now you do all the intravitreal maneuvers. So this was one recent patient which we were doing. This was a young gentleman, decreased vision for a pretty long time. The anterior segment slit lamp had evidence of uveitis with synechia, but patient had a detachment also, had cataract also, irregular pupil. So challenge was whether to do cataract surgery, combine it, do a lensectomy, or eat away the lens at that time. So mentally we prepared for each and everything. So this was the fundus picture. BCVA right eye 6/60, predominantly nasal artery. You can see part of the retina here superiorly attached, but you see nasal part is detached, but macula also is off. So let's see this surgery. So here, biplanar, you can see this, pigment on the surface of lens. And then I did depress. If you noticed, I did depress here and see here that, it is inside. So we started doing the vitrectomy. Initially, you could see, but now the illumination has decreased suddenly. This cannula, the light pipe is seemingly subretinal, but I continued. I did not take out this light pipe. You can see this reg component here. A lot of pigment on the surface of retina. Then on the right side, because it was inside, we injected PFCL, some amount of PFCL, just to displace take out this fluid, and did as much vitrectomy as possible. So this time I realized more job has to be done. There was some PVR, so took a chandelier 25 gauge. Now illumination is very good. So if there is sudden decrease in illumination, you should be, that's a red flag sign. And then you peel off this membranes, and there are multiple breaks you can see here in the upper part also. And remove this PVR, localized PVR here. And whatever membrane dissection you can do, you should, without much change of instrumentation. If you keep changing instrumentation, then it's an issue. So, in any case, we tried to remove all these membranes here. Then usual principles of ER surgery, diathermize all the breaks so as to identify them during fluid exchange. And then I removed the PFCL. Notice what is happening is this retina is becoming balloonous now. This just does happen once you remove this. And you see this air is coming in the subretinal space. This was, I hope you noticed that once we started airflow exchange, remove the PFCL. This is the air part. In the lower part, there is air in the subretinal space. So again, this became subretinal. So put another, remove this infusion cannula from the infratemporal quadrant, made another port. Now this eye has 5 ports inside. Did not touch the lens till now, this stage. Now it has become again very nice, and once we remove this air from this retinal break here, this was the air, this will come out, and then did the routine airflow exchange. Now this patient had multiple breaks. One of them was iatrogenic, and others were pre-existing superiorly as well as inferior. This patient already has had procedures done before. So then you do complete airflow exchange. Now it's reasonably nicely settled retina. Put in the oil and do a reasonable good amount of laser in all the retinotomies, iatrogenic as well as the pre-existing. There are 4 or 5 breaks here. So the lesson learned from this patient was, this was the post-operative picture. The nasal retina, everything is well settled. Patient did gain 6/18 vision. Siliconal reflexes are still seen. These are a couple of pictures I gathered during the surgery from the camera itself. So if the tip of the port is not visible, obviously nobody will venture and start. But if the illumination suddenly becomes less, so you should be cautious that why is this happening. Or if the RD becomes suddenly balloonous, be very, very careful. Or if the air goes separately, as I showed in the last video. It's very important that avoid frequent change of instrument. Otherwise, you may create dialysis by forcibly inserting the instrument through the trocar cannula, and sudden movements can lead to a lot of issues. And try as much as possible to maintain your calm. Very important is to change the position of the ports. This is, I think, the best part. Take a chandelier and change the position of the ports. And port entry should at this time be one step and vertical rather than two step and angulated. Especially in situations, as I had mentioned, uveitis and end of my patient, this patient had uveitis and a hypotenuse eye. So such patient always start with a vertical entry. And you may, end up avoiding multiple punctures in the choroid. So this is what I wanted to share, 3-4 cases where I had personal issues and how we manage this.
Thank you,
So
sir.
if anybody else has experience of this, I would love to hear and maybe
please.
share.
Any comments from the audience?
If you thought you saw the infusion cannula but were not quite sure, almost always it is subretinal. So it's better not to proceed. If you have the slightest hunch that you have not visualized it, it's better to assume.
No, first time when I started, we saw it, therefore we started.
No. I'm just making a general comment.
That's true.
And the second point which you
It may, you're right, it may happen in the beginning or it may happen intraoperatively also. Once your retina suddenly becomes balloonous, it can happen suddenly also. After you have started with a very good protocol that you saw it, everything was good, like this patient, then it can become subretinally during surgery.
The other way of trying to ascertain whether it is intraocular is to put on the indirect and see the and press down. Another point which you may add to that list is when you turn on the infusion, the globe doesn't quite firm up if it is subretinal. So that should be a subtle hint that it's not in the right place.
Yeah. You see, I 100% agree with you, but problem is during the procedure. Initial part, I think everybody will take precaution, whether needle infusion or like you were saying infusion. But problem I faced was during surgery it happened. And during surgery then you are uncomfortable. What to do, what not to do, because especially if it is a complicated patient, media compromised by uveitis and cataract, so then it becomes an issue. Then I think best is to change the ports and go straight. And initial part you have to maintain calm, that do not force your instruments inside. If you force the instruments, then especially upper nasal IOS, you may create a dialysis or a break there. So you have to be very, very gentle. Whatever you are seeing, very, very slow, gently you can do. Because it's a myth that, once the retina becomes balloonous, this retina with vitreous can get incarcerated there also if you move too much.
Excellent teaching points, sir. I just want to add about the intraoperative cannular disinsertion. So a few areas where we should be careful, like during indentation in that area, your assistant might not be very well trained, so he might disinsert that cannula or partially disinsert, so it's in the suprachoroidal space. And the second is while you're doing a GA case and the patient becomes light sometimes and there is a violent movement, and that is one area where the cannula can go into the suprachoroidal space. There's a few points we have to constantly see again and again whether the infusion is inside or not.
Excellent, Vishal, because I also encountered one of this, because the room generally becomes dark at that time, and if the assistant is not very careful, if you are not, you're shouting too much, so if he will move the lens or something, suddenly this infusion cannula will come out, and then you may have issues.
Thank you, sir. Always, we listen to Dr. Lalit, we learn a lot. Just one or 2 points which I've practically experienced. One is whenever we are all using MIVS these days. These cannulas we are using and reusing. So the cannulas may become a little they may not be locking. So make sure that once you put your cannula that it will lock it. Second thing is put a tape on the tubing that comes so that the assistant cannot remove it. Third, in cases of doing a choroidal detachment, I still use a sutured 6 mm cannula rather than using an MIVS, because I want to be sure that I'm inside. I do a hybrid vitrectomy, I do a sutured, I still have a MBR blade, I still have a 20 gauge cannula in my OT, so that if required we can use that. So don't shy from doing that.
So no, I agree. This is another practical point which Ajay has told, that put a tape there so that movement is restricted or less. So minimize the chance of sudden jerks. So both these points, I think Vishal and Ajay, we should add to this list, that sudden removal of this. Thanks. Thank you so much.
Sir, just to conclude, I would just like, please, if you could just highlight the signs which we can see if our cannula is displaced subretinal or suprachoroidal, just before to conclude. The signs, interoperatively, what will happen suddenly that we should fear that our something has gone wrong with our cannula?
RD will become suddenly balloonous, your view will be lost, you will not be able to, whatever you are doing, you will not be able to see much. And if RD suddenly becomes balloonous or choroid detachment starts happening, then it's definitely something wrong. So at that point of time, plug it, and then what I will do is take a needle infusion or a AC maintainer just to firm up the globe, and then reassess and do maybe indirect at that time, and then restart the entire thing.
So one very specific point which I have noticed is that the turbulence, the movement of the intraocular fluid becomes absolutely static if the cannula is not in the vitreous cavity. Suppose you have injected tricot for PVD induction. Normally, if you aspirate the the tricot, the crystals will move in a very rapid way into the port, if the cannula is in the vitreous cavity. But if it is in the suprachoroidal, it's not moving, it's just stuck there. So that is something wrong.
So absolutely. Correct. The dynamics inside the eye will change. Same like when there is a vitreous loss during cataract surgery. So you come to feel that something is going wrong. The RD starts becoming balloonous, the vitreous is not sucking, the fluid is not coming. So you have to be very careful. And sir, just one point, I think you have mentioned already.
If those instruments are not obeying what you are doing, suppose I am pressing the foot switch and it's not happening, the crystals are not moving, tricot crystals, there should be alarm.
And with this MIVS thing, it has become easy, as sir has also piloted. By indentation, there are high chances of the cannula going subretinal. So another advantage is you can just remove the cannula and put it at a different site, so that you have to be fast, because the more late you become in this, the more chances, the more difficult it becomes.
Yeah, if you indent too much, then the cannula is like this. If you indent too much, this will become subretinal.
Sir, can I make a point?
Yeah.
Sir, also with valved cannulas, this issue is less, sir, because the turbulence when we move.
Turbulence is less.
Less.
Also using.
You see, in India, problem is all these things are very good points, but all of us can't afford valve cannulas. A new patient, new every time. So the valve becomes ineffective after 2 or 3 cases. So you are right. You see, as far as possible, we should use valve to avoid turbulence and maintain fluid dynamics. That is the best, there's no doubt about it.
But sir, just I want to make a point, even with valve cannulas, this problem is there while indentation, because I had it just recently, because when you indent it, as sir said, the direction changes, and there are chances it may go into the suprachoroidal or the subretinal space, whether wild or non-wild.
All these are some tips to minimize all these issues.
Even using 3 mm or 3.5 mm, not going to 4 mm, even in phakic eyes, it will reduce the incidence.
Yes. Yeah.
So how you advise to?
Yes, you want to make a point? Yeah.
Wanted to make a point.
From this angle? Yeah.
Yeah. So in case you cannot see the cannula, if you think
because of dense opacity there.
Because of dense opacity, like in endophthalmitis, you can initially do your vitrectomy core and the anterior vitrectomy with AC maintainer also.
Yeah, even in phakic eyes, you can put AC maintainer.
We can put AC maintainer until we are able to see the, get enough amount of clarity in the vitreous. Then we can put the.
See, what I would do is I will do a core vitrectomy and then indent, too heavily, and with the left hand try to, remove that muck or with dense hemorrhage around the cannula, and be very careful not to touch the lens at that time. Because the direction of indentation should be not like this towards the vitreous cavity, and then you can, loosen that tissue. So it may take some time.
Your point of a dense vitreous hemorrhage, I am not able to see the cannula, or an endophthalmitis, I am not able to see the cannula. I will not start my cannula. I will take the infusion with a hard tip in the other port, which means I'll go well inside in the mid-vitreous cavity. When I'm sure before, if I've done an ultrasound, there is no detachment, I will start my vitrectomy. I don't need light because the microscope light is enough for me to do an anterior vitrectomy. Once I've done the anterior vitrectomy, I can see the cannula and you're done.
So the other thing you can do is second case which I showed, to take a needle infusion and connect it to the infusion. Needle will definitely be inside. Needle will definitely, you can see, and then do a vitrectomy, and after you have done most of it, then recheck infusion and do it. So needle infusion does work, or AC maintainer also does a good job.
Yeah. Just to conclude that point of your not seeing the cannula, there are very few cases you cannot see the cannula. So there are two ways of seeing the cannula. First is you manually indent that cannula part and see the tip. But sometimes, like you said, in dense vitreous hemorrhage, it cannot be visible. And going with the needle from the opposite port is not always visible in phakic eyes. You might have a risk of touching the lens. So if there's a dark room, you switch off the microscope light, take the endo illumination, and from the opposite side, shine it. And that steel part of the cannula will be visible even in very dense hemorrhages. So that is one way. One way is indenting manually, and the other is shining that cannula, the steel part of the cannula with the endo illumination. That the cataract surgeons also use the endo light in hazy corneas to do phaco these days. So that's a very useful technique.
So I think excellent discussion, and I think the last question was very important point. You should not switch on your cannula if it is not visible. I think this is the most important thing. So what you answered, everybody has cleared all your doubts. But if you're still not able to visible your cannula, or if your cannula is visible and it is in the subchoroidal space, then it is a problem. So in phakic eyes, it is always difficult to go from the opposite port. So what you can try is you can go from the port which is present above. So what normally is recommended in pseudophakic and aphakic eyes, you go from the opposite port with a cutter or anything, you indent it and you try to release it, and when the tip is visible, it's good. And in a phakic eye, you can try to go from the port which is present above it, rather than going from the opposite port, to prevent the risk of lens touch. But you have to be very careful. The tip should be visible before you proceed with further surgery. Or probably even you can change the direction of the cannula if the tip is not still visible or is in the suprachoroidal space. Okay. Thank you, sir. Thank you very much. I think it was a very nice talk, very learning talk for everyone, and a very nice discussion. So the next topic will be, I'll be speaking on the management of bleeding during diabetic vitrectomy, and I think I will be able to answer the question which was asked in the first session. A very good morning to all of you. I would again like to thank all of you for attending our session, thank all our speakers, and Dr. Lalit Verma also, who also joined us. So I'll be speaking on the management of bleeding during diabetic vitrectomy. I think diabetic vitrectomies are one of the most, can become one of the most difficult cases for a VR surgeon, especially during early times. And if there is a bleeding, then it becomes absolutely difficult to proceed. So it's like a war. You have to prevent bleeding and you have to also prevent the formation of retinal breaks. So I always think that, I always instruct that the hemorrhage have to stop first before proceeding for the surgery. If you allow the blood to spread and the bleeding will continue, then you can't proceed with the surgery and it might become a problem. So with the advancement in the technology, the bleeding risk has greatly reduced, but still, it is still there. Now we have got smaller gauge vitrectomies, better viewing systems. We even got chandelier system, but still vitrectomy is a major complication in diabetic vitrectomy. So I'll be approaching from a step-by-step approach. So this is like a simple case. The blood is there. There are mild bleeders which are there. Most of the dissection now, I think we do with a cutter only, with the 25 gauge cutter or 27 gauge cutter. You can go very close to the retina. You can sit on the retina and do most of the dissection. So this is a case in which there were mild bleeders were there, and just with the help of a endo laser or with the help of a diathermy, you can just close these bleeders and you can proceed with the surgery. So this is not much of a problem. So I'm just just diathermizing these bleeders. You can also use laser photocoagulation to close these bleeders, and there's not much bleeding and there are no breaks. So in the end, you just do a pan-retinal photocoagulation, and there is no need of any tamponading agent in such a case. So this is the first thing. If there is a mild bleed, you can just cauterize it. And a bimanual approach is very helpful in such cases. You can aspirate with one end, and with the other end you can just diathermize those bleeders, or you can proceed with the laser also. So I always prefer to cut the hyaloid first in the periphery and then come to the posterior pole. If you come straight away at the posterior pole, sometimes there is chances that there is a very risk of a very severe hemorrhage because of the fibrovascular proliferation of the disc. So what to do next if the bleeding is not getting controlled or not able to localize the bleeders? And you just raise the IOP. Now we have got excellent machines. You just have to press a button and the IOP is raised. But the important point is here that you have to monitor the time. The perfusion of the disc in such cases is usually compromised. So you don't have to keep the IOP high for a very long time, not even more than probably 1 or 2 minutes. It's very important to bring the IOP down and look for the bleeding again. We have to monitor arterial pulsations. If there is any presence of any arterial pulsations, then you can't raise the IOP. So this is very important. This is one of the reasons probably you have done an excellent surgery and you have got a PL negative eye the next day. So still, if you're not able to control the bleeding, so what to do next, even after raising the IOP? So this is a case in which I did outside in approach. As I said, I'm first dissecting the peripheral vitreous. Now you can see there is a dense fibrovascular proliferation which is present at the macula and at the optic disc. So while doing the dissection, there is presence of severe hemorrhage which was present here, and I was not able to control it. So I'm doing again most of the dissection with the help of cutter only. So this is a case in which I'm doing a diathermy and just raising the bottle. So I'll just discuss the next step. So again, in this case, most of the dissection is done with the help of a cutter only. You can see you can dissect most of these membranes with help of these cutters, go very close. So again, this is a case in which the bleeding was controlled with the help of raising the bottle, or you can, even if the bleeder is visible, you can just apply gentle pressure with the help of your cutter only or with a back flush directly onto the bleeding vessel, and in most of the cases the bleeding will stop. So in this case, in most of the diabetic cases, we also do ILM peeling, and this is again followed by a pan-retinal photocoagulation, and luckily no break was created, so no need of any tamponading agent also. So this is another instrument which was developed. I've not used it, but I think it is a very interesting instrument. So this is the end aspirating endolaser probe. So with this, while doing a laser, you can continue to remove the blood surfaces and you can continue with the PRP. It can also be used to treat the bleeders by the endophotocoagulation. I've not used it, but I found it in the literature, so just thought to mention it. So what to do next? If the bleeding is still there, you plug all the ports. It is always better to use valved cannulas. We have to wait for 2 to 5 minutes. In most of the cases, the bleeding will stop. You can clear most of the hemorrhages and proceed with the surgery. So important here is to wait for about 2 to 5 minutes. So what to do next if the bleeding is still not getting controlled and you can't see the bleeders? The next step is using PFCL. I use PFCL quite liberally if the bleeding is not getting managed. So this is another video. Yeah. So in this, there is a thick fibrovascular front which is present in the disc, and the bleeding was not getting controlled. So I could not remove the membrane. So PFCLs, these are heavy liquids. They tamponade the retina. They close the bleeders. They even act as a third hand. You can proceed with most of the surgery. You can do some membrane peeling. The important thing in diabetes is you should never pull a membrane straight up. It should be tangential, or you should dissect it. So in this case, since the bleeding was not stopped and I was not able to do most of the dissection, I injected a bubble of PFCL, and with the help of PFCL, now under PFCL, I was able to remove this membrane. You can see this membrane has come out gently, but again, you have to be very careful. There is a risk of creating breaks, and in diabetic cases, it is inevitable sometimes, and sometimes you create a break. But again, in this patient, the break was not created. So if a clot is formed, what to do? If a small clot is formed, my advice is never try to remove it. But however, if a large clot is there, probably you should try to remove it. If a rebleeding occurs, then it's much worse. So in this video, there was a clot which was present. A pre-retinal clot usually will not cause much problem. There was a clot which was present and it was bleeding persistently. So I decided to remove the clot. So this is just to highlight that sometimes if the bleeding is stopped and the clot is not large, then it's better to leave it. So I proceeded with the pan-retinal photocoagulation, gave the PFCL some time to pressure tamponade the bleeders. So after that, I removed this clot. So you can see with the help of a back flush, I removed most of the clot. But unfortunately, and I think it will happen in most of the cases, at the end of the surgery, the clot again reappeared at the posterior pole, but then I decided to leave it because it is a small pre-retinal clot which is present and it will eventually go off. So although I have successfully removed the clot and I'm quite happy here, but once I did the air fluid exchange in the end, you can see the clot is again formed. At this stage, I decided to leave this blood, and definitely this amount of blood will not cause much problem. So it's always better not to run after clots, because if a rebleed occurs or if the bleeder opens, then it will lead to severe worsening. So this was another diabetic case. This was a tabletop detachment, an old TRD. You can see there is a thick fibrovascular proliferation. So I injected again under PFCL, again tangential traction. It's risky, but again lucky for the patient and for myself. Most of the membrane and the traction was removed under PFCL, and then dissection was done with the help of a cutter. So most of the detachment in this case was present in the center, in the macula. The periphery was attached. So after successfully removing this whole of this fibrovascular proliferation from the retina, I did a peripheral photocoagulation, and again, since no break was created, these TRDs usually take time to settle. So you can see that the peripheral retina is settled. However, the detachment is here. So I just did a photocoagulation in the attached retina and the periphery, and left this central part, and it took time to settle, but eventually it will settle. And if you have not created a break, one important thing while using PFCL is that if there is a traction and you have created a break, then the PFCL will go subretinal. So you have to avoid creating breaks, and if there is a break in the area of attraction, then you should avoid using PFCL, or you have to be very careful, because if attraction is not released, then the PFCL will go subretinal. So this is another case. This was a one-eyed patient. This patient, the one eye he had lost. This was his other eye. You can see the patient has got a thick fibrovascular proliferation involving whole of the disc and the macula. This was a huge challenge for me, but the patient we didn't had any other option apart from operating it. So I've cleared all of the peripheral vitreous. I've done a panretinal photocoagulation, and now I'm dealing with this central frond. So there is a continuous bleeder which is happening despite everything. So I injected a PFCL bubble, and I'm tilting the bubble, continuing with my dissection. In this case, I'm using a scissors because I'm directly over the fovea, and I wanted to be very, very careful because this was his only eye. So sometimes you can just tease these membranes, and you can find a plane, and then you can just go beneath the plane and continue with your dissection. So the PFCL the eye was rotated to tamponade the bleeder, and then it was rotated, and the dissection was continued further. So in this case, after releasing all the traction, I did not remove all of the fronds which are attached. My aim was to just relieve all the tractions, do the minimum risk so that the patient has got some vision later, some mobile vision later in his life. So you can see most of the membrane has been, most of the traction was removed from the macular area, and a dissection has been done. So this was the fundus picture at 1 week. You can see there are some fibrous fronds there, but the fovea is clear. This is the picture at 1 month. This is the montage picture at 1 month. This patient gained a vision of 6/12 and was reading a newspaper in my OPD, and that is one of the most gratifying things. So still, if the bleeder is not localized despite all your efforts, and still there is a continuous bleeding, you should not operate in the blind. It's always better to close the surgery, do not create any breaks, and replan the surgery after a week. But there is also one more thing which I have done in 3 or 4 cases. There were some publications of leaving the PFCL inside the eye, which has been done for GRTs. So what you can do if there is a persistent bleeding, you can use PFCL as the tamponading agent, but you have to be very careful. You have to remove the PFCL after 3 to 5 days and replace it with either gas or silicone oil, because the PFCL could be toxic to the retina. It can lead to retinal toxicity and to damage of the retina. So this is another option, and I've done it in 3 to 4 cases, and it is very effective. It will definitely stop all the bleeders. But the important thing is you have to be very careful for the inflammation and the retinal toxicity, the pressure, the mechanical pressure toxicity. So you have to remove the PFCL. So again, the prevention is best before operating a diabetic case. You have to take control of the diabetic status, the hypertensive status. You have to stop all anticoagulants, antiplatelet agents. Anticoagulant use are associated with a higher risk without any serious consequences, but they increase the duration of the surgery and may also increase the risk of post-operative hemorrhages. So diabetic cases are one of the cases in which you would like to stop all these antiplatelet and anticoagulants. The hypertension, the sugar, and should be under control. Even the hemoglobin levels should be under control, and a prolonged surgery always increases the risk of intraoperative and post-operative bleeding. So this is one thing which has really revolutionized the treatment of the management of diabetic TRDs. I prefer to give in almost all of my cases 3 to 5 days before. I prefer to operate at 3 days. So they have really reduced the risk of bleeding. They have made the surgery much more safer and easier, but still there will be some bleeding in cases in which there are severe hemorrhages. So putting it all together, just to conclude, I think everybody has its own technique, but these are some useful tricks. It's always better to use valved cannulas. Chandelier systems are excellent. You can have a bimanual approach. You can aspirate with one hand and you can do the laser with the other hand. It's always better to cut the hyaloid from the periphery and then come to the center. You can use active aspiration from one hand if you're using bimanual surgery, and you can do the coagulation with a laser or a diathermy. It's always better to use pre-operative anti-VEGF agents. We should not pull a fibrovascular proliferation. It's always better to do it a tangential traction, and that too under a PFCL if possible. A difficult to control hemorrhage at the disc will prevent the further surgery, and probably you'll have to inject silicone oil also, which increases the risk of post-operative high IOP. So use of PFCL, as I have highlighted in my presentation, it gives a clear media, it pressure tamponades the bleeders, it also gives a better laser reaction, it gives us time so that you can continue with the PRP, and it's very important to if you have left PFCL at the end of the surgery because of a continuous bleeding, it's very important to reoperate after 3 to 5 days and remove the blood. So thank you, all of you. Yeah.
3 to 5 days. I've seen that the PFCL goes subretinal also sometimes through a small break. So is there a way to remove it?
See, so definitely there is a way. It depends where the PFCL bubble is. So first of all, as I said, if there is a traction and if there is a break. So the most important thing, you have to avoid the formation of a break. If you have formed a break and there is traction, then only the PFCL will go subretinal. If there is no traction, the PFCL will not go. So it depends on the location of the PFCL where it is. If it is extramacular, probably with a simple backflush, you can remove it. Now again, if the PFCL bubble is at the macula and it is usually stuck, you can't create a retinotomy. So the best way is, which has been described, I have not done it. It is to create a retinal detachment. You have to create a retinal detachment by injecting fluid above the macula, and then probably that will loosen the PFCL bubble, and then you have to aspirate it from there. Or again, then you have to probably create a larger retinectomy, go behind the retina and remove the PFCL bubble. But you can't leave a large PFCL bubble at the submacular area. It will eventually damage the RP cells there. So the important thing is to prevent it, because having a subretinal PFCL at the macula is a very, and usually these bubbles are very, very small. You can see them on OCT. So you have to create a small retinal detachment with the help of a 41 gauge, and you have to displace it and then absorb it from there.
No, the issue was that intra-op you do not see any subretinal PFCL. You don't even identify a break, but post-op you see that PFCL is behind.
That's what I'm saying, and that also you will identify probably after 2 to 3 weeks.
Yeah.
So another important thing is the vision of the patient. How bad is the vision? If the vision is probably 6/18 or better, I would probably not do anything. I will leave it. If the vision is worse than probably 660, then probably I would like to intervene again. You have to create a retinal detachment. You have to dislodge the PFCL bubble because it is stuck there. You can't just create a retinotomy on the fovea or near the macula. You have to create a retinal detachment, and you have to absorb it. Or there is one more technique, as Dr. Ajay said, you flush it and remove it. But PFCL bubbles, they usually come out once you create a retinal detachment. You just have to aspirate it.
Can I answer that question? Wonderful presentation, Bhuvan. So I have had two situations like this. One is the bubble of PFCL is subfoveal. Second is the bubble is extrafoveal. If it is extrafoveal and not compromising vision, I would see that it is not moving around. Some people have even described a little laser around the bubble so that it stays there put and doesn't move around. And then the vision remains. If it is subfoveal, a small bubble, and is likely to compromise vision, what I did in a case, I'm not saying it was right, it worked. I took a 40 gauge cannula. It's an expensive way of handling it. Identified the bubble on the OCT. Ideally, it should be done with an intra-op OCT. I don't have an intra-op OCT. Went in through the fovea with a 40 gauge thing, one shot inside, removed it, done. Obviously created a small foveal break, but the patient's vision improved. So that is one way of doing it. I'm not recommending it, but it worked for me.
I think yeah, that is very important.
Near around the posterior pole, the chances of it going back are more. Only if you are suspecting that you will angle the break a little beyond, then you get PFCL. PFCL does reduce that, stops that
Yeah, that I've mentioned. That is the last.
And when you inject PFCL, inject it as a single bubble. So don't. So when you inject, don't inject from a distance. Get within the bubble. Allow it to enlarge, because if you have multiple bubbles, then it's tough. So that's what.
And just one more point. Once you have displaced the bubble, you can also inject PFCL over the retina to displace the fluid from the center of the macula. So over it, so that the PFCL bubble is pushed away from it, and then you can aspirate it from a retinotomy created.
Yeah, I just wanted to move away from perfluorocarbons just a bit, just to emphasize the points that you made. Now we are all carried away by the capabilities of the newer machines and our own surgical skills, and we set out to achieve what may be anatomic marvels, but functional disasters. So it's always good to combine technique with temperament and not go after every single fibrovascular proliferation, as you rightly said, an extramacular fibrovascular proliferation or a benign proliferation over the disc. You want it to be removed, and then you have a massive bleed. So it's better to know when to stop.
It's like a creeper. Sometimes you have to let the root be there, remove the creeper.
Sir, I have one doubt in the CKD patients, it just doesn't stop bleeding, it just doesn't clot at all, who are on dialysis and, these kind of patients. So, do you advise them dialysis the day before the surgery, or does that make a difference?
Personally, I don't think having a dialysis before surgery, I don't have any experience. I don't think so it will make a difference, but probably if anybody.
So we had a patient who I operated 2 times, and then I went more into greater details. This is many years back before we started understanding this. So whenever I have to operate these patients, I convert them to a heparin-free dialysis. Second is, if many of these patients actually do better with the peritoneal dialysis rather than a dialysis on the normal. So a patient who was bleeding repeatedly, we had done all laser, everything, still he would come back with a small bleed. So we converted them to a peritoneal dialysis. It works well. If it is a dual drug, I stop it for 6 days. If it is aspirin, stop it for 4 days. If it is clopidogrel, stop it for 6 days. I think it is very important. Other thing which I think Dr. Mahesh has been doing is to use patient's own plasma for the thrombin, which can be used intraoperatively to make a clot, which is useful.
You were making a comment.
It's a bi-weekly dialysis. I ensure that my surgery is midway or immediately after the dialysis, so that the next dialysis is a little away from my surgery.
Absolutely. Yeah, that is important. The next dialysis should be a bit away.
Thank you, Bhuvan, for including me in this IC, which we have been doing for the past 2-3 years, and this is one of the most popular ICs in Retina, and as you can see from this flashback pic of 2019, a huge hall full of people even sitting on the stairs in this wonderfully conducted course. I'll be speaking on intraoperative globe hypotony, causes, sequelae, and management. No financial interest in any of the products used here. So though rare complications related to retinal surgery can have serious results, fortunately most are preventable. The most common complication which we have heard is perforation, light toxicity, drug toxicity, post-operative hypotony, iatrogenic tears, etc. But very little has been discussed and talked about intraoperative hypotony. It is rare because of modern VR tools and advanced fluidics, but it can occur in the hands of the most experienced surgeons using the most modern machinery. Early recognition and management in any complication prevents potentially devastating complications. So the basic denomination of intraoperative hypotony is, of course, the mismatch of infusion and aspiration, and that can be due to many causes: blocked or leaking infusion cannula, kinked cannula, your suction is high and it's not matching to the bottle height, active aspiration under air using non-valved cannulas, and of course accidental unnoticed infusion disinsertion while working under air using active aspiration or instrument exchange under air using non-valved cannulas. These are the many causes of mismatch of infusion and aspiration. And complications can occur because of intraoperative hypotony depending on the time initial to the just at the start of the surgery or the middle of the surgery, like bleeding, iatrogenic tears, lens touch, corneal edema, hazy view, submacular hemorrhages, especially in high myopes, and choroidal detachment. Coming to the management, the first line of management is to identify early signs of hypotony. Next is to identify the cause. And the last is to manage complications that have occurred because of this complication. Checking machine parameters, the bottle height, your infusion cannula, and a strong vigilance to the surrounding part of the surgical field. And of course, plugs should be placed in non-valved cannulas to secure fluid flow, airflow through the cannulas, which can prevent hypotony, especially in air-filled eyes. Coming to the videos of various incidences of intraoperative hypotony. This is a case of traumatic endophthalmitis, and it is an inflamed eye, and the block did not come well, and it's a shallow orbit, and the patient is squeezing the eye. Now what is happening here? Sorry. What is happening here is because of the squeezing, the infusion pipe is it's just adjacent to the lid margin, and it's getting constantly kicked, and it's causing intraoperative hypotony. So always remember in shallow orbits or where there's a lot of squeeze, you take a break, you augment the block, whether external peribulbar or subtenal, like we did in this case. Make the patient comfortable so that the eye is wide open, and the cannula pipe is not touching the lid margin, it is not getting kinked. Here a posterior subtenal block is being given intraoperatively. And the surgery went off fine, the patient was comfortable, the doctor was comfortable, and the results were good. This is a video to highlight active aspiration causing intraoperative hypotony under air. So of course under air the pressure dynamics are different, and if you use active aspiration with the cutter, these are causes of intraoperative hypotony. This is a routine macular hole surgery, and after the ILM peeling, we are going under air and aspirating with the cutter. This video is just to highlight, you see, the active aspiration of the air causes this hypotony, and you can see the disc margin getting hypotenuse. So this is not of much consequence in this case, but if you are using that same maneuver in a diabetic case, and after the laser when you go under the air, and you are using too much excessive active aspiration with the cutter, it can cause resurgence of bleeding from the already cauterized breaks or bleeders or new bleeders, which can cause clot under the air and create a messy picture in a very well performed surgery in the end. So this was an active aspiration with the cutter under air in a diabetic vitrectomy, which can be of consequence. Of course, as we have discussed before, always use a 6 mm cannula if the tip is not visible, and even in some cases of dense vitreous hemorrhage or endophthalmitis, you might have to dissect tissue from the tip of the 6 mm cannula even. It might not be in the intravitreal space, even the 6 mm cannula. So you have to be sure to see the tip properly. Like we are going from the opposite side from the cannula, and we are using the trocar cannula to dissect the tissue from the tip of the 6 mm cannula, and we are sure that the tip is inside the vitreous cavity before starting the infusion. This is one case of a macular hole surgery again, in which another point to highlight is when you inject the dye to stain the macula and you wait for 30 seconds or 45 seconds and your instruments are perhaps out, and then you do not recheck while going inside that the infusion is in place. And that is what happened when we went inside during the peeling part. After the staining, we see this choroidal detachment because of a disinserted infusion cannula. Of course, we went off the surgery, reinserted the cannula, and the post-operative results were fine. So you have to always check while your instruments are out during a waiting period of 30 to 40 seconds during these macular surgeries. This video highlights an important point. This was a case of a dropped nucleus in which the IOL was placed in the sulcus by the operating surgeon and was referred to us. Now here what happens is, the first cannula is made. It's a walled cannula. The second cannula is made, the port is made. Now at this point, the ideal thing should have been to attach the infusion port. Just thinking that it's a walled cannula, it will not leak is a mistake, because some leakage is within the walled cannulas also. And secondly, it is a phaco done without any suture here. So some amount of indentation while pressing through the ports will cause the AC leakage, AC flattening, and the globe will be hypotenuse. Now, while making the third port with the MVR for a frag, you see the hypotony, and because of that, some trickle bleed or some bleed from the pars plicaita area, trickled into the posterior pole, and you can see that red reflex. So the infusion should have been placed immediately after making the infusion port. Of course, this could be handled in this case, but it can create a mess in the posterior pole and a hazy view during the phagofragmentation. These cases of myopic RDs are very notorious, high myopic RDs, pathological myopia. Even if you give pressure, putting a pinky or a hand pressure after giving a periorbital block, the choroidal capillaries are so fragile that they can, cause intraoperative subretinal choroidal bleeds. Like in this case, a small streak of bleed is of no consequence and you don't have to aspirate as discussed in the previous presentation. But this is the second case of myopic RD, and you can see a massive subretinal hemorrhage encroaching the posterior pole is there, and you cannot leave that amount of bleed intraoperatively. So you have to make a large retinotomy, inject PFCL of the posterior pole so that the bleed is ironed out through the peripheral break, aspirated, and laser the retinotomy. So you can leave a streak of bleed subretinally after hypotenuse intraglobe hypotony, but you cannot leave a significant amount of blood intraoperatively. Another sequel of intraoperative hypotony. So this was a typical retinal detachment case, and we are proceeding in the usual way. And now we are coming to the PVD induction part, and we have injected tracard. Now you can see the telltale signs of intraoperative hypotony, as I mentioned in my comment from the previous speaker, that there is the whole fluid is static. There is no movement of the tricot crystals. The vitreous is not cutting properly, and your instruments are not obeying your foot switch actually. So there is something wrong, and we inspected, and there was a disinsertion or a kinking of the infusion cannula. We reinserted the infusion cannula. Everything went fine. Now what happens here is, after that, the media becomes suddenly hazy. The crystal clear picture before that event was not visible, and we could barely see the retina. So what happens is, while you are indenting in a hypotenuse eye, there is a lot of oozing from the iris root, which goes into the AC. So you don't need to debride the epithelium for that. Whenever there is an intraoperative hypotony and you resume the surgery, and there is a media haze, you go into the anterior chamber. You can see that diffuse blood in the anterior chamber, which was not there before. You just watch the AC and then go inside, and the view is again crystal clear as it was before the event. And of course, no amount of blood, significant blood should be left inside. And this was a referred case to us with intraoperative cannular disinsertion, and the clot accumulates, it creates break, it contracts and it creates break, and there's a lot of PVR in the periphery, and it's very difficult to dissect it, and finally you have to make a large retinectomy, relaxing retinectomy, to settle the retina. So any amount of significant blood should not be left inside, or if left inside in the first go, should be immediately removed in a week or so, not left for a long time, so that the clot contracts and creates the iatrogenic breaks. This is the last video, and this is something where the intraoperative hypotony actually held us. So this was a GA case of optic disc pit. It was an 8-year-old male, and as I said, there was the anesthesia went light, and there was a jerking on the patient's head, and the cannula got disinserted, and while our instruments were inside. So this is the PVD induction. So this is where the cannula got disinserted, and you can see the pulsations of the disc pit from this part, because there is intraoperative hypotony, and the negative pressure is allowing the fluid from the disc into the vitreous cavity. And here we could delineate the whole size of the pit because of the intraoperative hypotony, because of the pulsations. And then we reinserted the cannula, and the surgery went off fine. We did ILM peeling and inserted the ILM inside the pit, and the patient did fine post-operatively. So to conclude, infusion misdirection resulting in hypotony seems to be infrequent, but it remains a risk. Awareness of the problem is very important. The potential to touch the retina, choroid, the lens increases when there is intraoperative hypotony, and can be avoided by maintaining the correct position of cannula by simple measures like placing an external encourage. Valved cannulas surpass non-valved cannulas in maintaining IOP, of course, and early management of complications are key to success. Less things go out of hand because of intraoperative hypotony. Thank you so much.
and we remove the infusion port, and the whole globe collapses, and so.
Yeah, so that is because of two reasons. One, you have not made a biplanar incision in the case of 23-25 cannula, you have gone directly. Or if your trocar cannulas are blunt and they are reused, so they are not making a perfectly sealed incision. So if that happens, normally what we do is some amount of conjunctiva coming after this insertion of the cannula. That will help it. But still, if you are using used cannulas and there is hypotony, you can take a 30 gauge needle and inject some amount of air or gas at the end.
Does that not dilute the SF6 or C3F8
No,
that
I'll
you are
just like to
putting?
first. I think Vishal has pointed everything. It can still happen if there is scleral thinning or high myopic eyes. I think whenever we remove a silicone oil end, we do the air fluid exchange. I'm always scared of the hypotony happening, and it is also common. So you should not be afraid to apply a suture even in sutureless vitrectomies. So if you feel that your ports are leaking, you're above 2, it's always better. You can even pre-place a suture before removing the cannula. Or if there is a hypotony, you suture the leaking port, and you can inject again gas to reform. You have to reform the pressure once there is hypotony and you have closed all your ports. So you can reform it either through a 30 gauge, you can insert a separate. If there is hypotony, there is sometimes difficulty. So you can insert it through the same, the incision is there, and you can apply a suture. That is the only way you can prevent if a hypotony has already occurred. So the prevention is you can use better cannulas, do a better insertion, but still it can happen, especially in high myopic in scleral thinning, and you have to reform the eye and apply a suture.
So one way of checking and preventing this complication, what you mentioned is, in a gas-filled eye, while you are infusing the gas, keep the pressure on the higher side and then disinsert the cannulas. Now you just palpate and titrate the pressure, and that you can, if it is on the higher side at the end of the procedure, use a 30 gauge needle and aspirate the excess gas. Don't keep it hypotenuse.
I usually stop the air. Yeah. What I do is I stop the infusion and see whether my globe is collapsing or not. So if it is collapsing.
No, he's talking of after injecting the gas.
Okay, after.
While removing the cannulas at the end of the procedure.
The above 2 ports I'm talking. Okay.
Yeah.
Vishal, wonderful presentation. But what he's pointing out is, here's a catch there. We normally use a 50 cc syringe, dilute it and use it. He's saying he's using a pure gas in a air-filled eye and injecting little bit, so that as all of us Indians we want to save, so we use lesser. Is that right?
Partly, sir,
so.
but even
no, we have to be
ISO
open. I do it sometimes. Yeah, we have done it.
So sometimes even the ISO expansile, even if you use a 20 cc syringe, it gets over by the time you've.
So that's why there is a French. We started doing that long time back. There was a French study which said 50 cc go up to 35 cc so that you can get an ISO expansile. 15 cc is still left. That one is used for all these events. But the trouble is, if you're using a 4 ml of cavity in which you have put in air, and now you're injecting 0.3 cc C3F8 to save on money, then you are stuck. So then the only issue is what Bhuvan said: inject whatever gas you have to do, remove those 2 ports. Third port, take an Alabama in left hand or any forceps, use a LIMS forceps and exert pressure immediately and have some gas ready. That's the only way you can do that.
Sir, in 20 gauge days, we used to apply the suture first.
Yeah.
Then while removing the infusion port, the assistant used to tighten it and the surgeon used to pull it out.
Right.
Pre-placed sutures.
Pre-placed suture. I think that will solve many problems.
Pre-placed sutures are very. Do you know, sometimes even if I feel that my eye after SOR have high chances of hypotony, I would still place a pre-placed suture and then go ahead with the. You can place a pre-placed with these systems also. They stay there.
But that post SOR hypotony is of actually no consequence if the retina is attached. It, generally.
See, hypotony, Vishal, in your present. I agree. If the retina is attached, but still hypotony can definitely lead to hemorrhage or a choroidal detachment,
Especially
recovery
in
late.
high myopes, you should always suture because the scleral rigidity is.
You should not be. There is no shame in applying a suture even in a sutureless. 23G में तो लगाती थे, 25G में भी ज़रूरत है तो लगा लो.
Yeah. So may I add one point, sir? For hypotony, we are working in a dark room, और बोतल खत्म हो गई. It's a long surgery, and we didn't discover that the bottle is empty. Even there is some fluid left, the pressure is not there, and the chances are that we are doing PVD
this-
induction.
This
suction
used
is
to
high.
happen earlier a lot. Nowadays, the machine keep on telling us that the fluid is getting empty. But you have to.
Not everybody has the iron
of course,
machine,
of
so-
course.
But let those last 50 ml go waste and change.
Yeah,
Yes,
it's
sir.
always better. Yeah.
And one more point for the beginners is never
No,
depend
sir,
on
the room is off and the surgeon is occupied elsewhere.
Sir, the assistant is never reliable. You have to check again and again by tilting your neck. So never rely on your assistant. He will say sorry, but the patient is yours. You will only have to be answerable. Yeah.
Go by a gut feeling. When you're operating, if the hypotony is starting to develop, you have a different feel of the whole thing.
Yes, sir.
Then you immediately stop.
You goes down the moment the pressure has come down. From, let us say you have kept 30, it has become 22. अपनी यहाँ पर बत्ती और यहाँ बत्ती जल जाए.
Sir, you are quite experienced.
Sir, but the,
At the time of service, at the end of the service. If there is no air, no gas,
normal.
normal. If there is gas, if your entries are perfect and not leaking,
If it is hypertonus, then it is cause of concern. Because there is a good chance of CRA occlusion. So I would want it to be normotonous. I would rather go with a 30 gauge and yeah. So it depends on the status of your ports and what is inside, whether it is fluid or not. Because with fluid, you can give a mannitol and it should be fine.
Thank you, sir. Any more questions from the audience, or can we please?
In one of my diabetic vitrectomy which required placement of silicone oil, in post-op period there was rebleed. So then how to go for it?
So under silicone oil there was a rebleed.
Yeah.
So see, first that depends. See, you can't laser. Of course, if there is a bleed, you can't laser. You have to wait for the hemorrhage to clear. But the important thing here is with silicone oil, with the bleed, the chances of increase in pressure are high because there is a closed globe. So you have to take care of the IOP in such a patient. And once the hemorrhage clears, you can go ahead for the laser. But if the hemorrhage is quite severe and the IOP is quite raised, then I think you have to operate again. You have to remove the silicone oil, you have to clear the blood, you have to stop the bleeding and then do the laser. You can't leave a eye, a diabetic eye with a pressure of more than 30 or 40, and these pressures will not get controlled with any medication. Because it is a closed globe, you have already put silicone oil and there is also a hemorrhage now. So it will eventually lead to optic atrophy, it can also lead to blindness. So I think you should not leave a diabetic eye with a pressure of more than 30 for more than 3 to 4 days.
Yeah, so
That,
then you have to go inside.
Yeah, it's not very bad, like I can see, but
yeah, if the hemorrhage is small, the pressure is fine, then you can wait, of course.
So you have
mild
to
details and the pressure is under control, you can observe.
okay. So pressure will be like guiding
So you have to
guiding
define
parameter for these cases.
You have to define the size of the hemorrhage, the location of the hemorrhage. If it is away from the macula, small hemorrhage, and you do not need to give particular tamponade, you put in oil, complete your laser, try to remove silicone oil early, make the patient sit up. And I do not know how many of you, I've had 2 situations recently where I had a similar situation, small bleed, and surprisingly the blood is in the perisilicon's place and is not clotting. The moment patient lies down, becomes submacular, the moment patient sits up, goes down. I just can't understand what is the logic. So in such a situation, I told him that I make him sit up, it goes down, because this is true for any cavity which has got like a pleural effusion. If you have fluid, it will not clot. So similarly in the eye, if you have 2 membranes between silicone oil and retina, it may not clot. That's the logic I have. So this is not clotting, so I make him sit up. Whenever he's ready for it, we'll remove the silicone oil.
See, if your IOP is fine, I think you should wait for 2 weeks. There is no problem because the hemorrhage will as such will not cause any problem.
Yes.
If your retina is fine, your retina is flat, you have done a laser, hemorrhage will not cause a problem. I think the main thing is the pressure. you can wait for 2 weeks.
Then it's the role of anti-VEGF?
Of course, pre-operative anti-VEGF, see, post-operative anti-VEGF at the end of the day, I don't think has any role, because in a vitrectomized eye, it will usually washed off. With silicone oil, if a fresh bleeding has occurred, under silicone oil, then you have to be very careful if you're giving an anti-VEGF, because the short life is reduced. So a half dose anti-VEGF is usually recommended if it is once clear and you feel that a fresh bleeding is happening. I think then only there is a role of anti-VEGF under silicone oil. In a diabetic case, more they require probably in PCVs or CNVM, these anti-VEGF are more needed.
The operation, at the end of the operation, you find there is no leak, and in the first day of the post-operative, you find this eye is hypotenuse. What's the ideal way to deal with it? To wait and see what's happened, or early intervene?
So day one, if we have got a hypotenuse eye, again, I think it depends on how much hypotony you have, and what is the state. If the retina is attached and there is a hypotony with mild choroidal detachments, probably, I think you can wait. You can give a pressure bandage. You can start oral steroids, and you can wait. You can observe the eye for 3 to 4 days and see whether the pressure is building up. But if there is a very severe hypotony and the globe is completely collapsed, then you have to go inside. You have to form the globe. Otherwise, it can lead to serious complications. Any other comments?
A pressure patch for 24 hours will do the job. If it does not, then you have to go.
And stop all anti-glaucoma agents.
Okay, I think.
So I think we should conclude our session now. We couldn't do one of the talks by Dr. Azad, but still we managed. We had a very good discussion. So thank you everyone for attending our session. Thank you our speakers, Dr. Vishal, Dr. Ajay, Dr. Lalit for contributing. And I hope we all learned a lot. I at least learned a lot. So thank you everyone.
Thanks all for coming.